Okay, we're back. Part 2, Chapter 16, Airway Management. Let's get started. So the airway management, BLS, let's talk about that for a second. We're not going to go over that in these videos because that's something that you're already certified in. That's something you should be satisfactory in. You know, you should have these skills already. You'll want to refresh them. Take a look at your text if there's something that you don't understand or you don't remember. Also, we'll be working on that obviously in the lab. So laryngeal spasm and edema, picking up where we left off. Laryngeal spasm, when we talk about that, it happens when the vocal cord suddenly snaps shut. So what happens is, as you can imagine, it completely blocks the airway. Now, sometimes it's triggered by a couple of different things. It can be triggered by trauma, like a rough intubation, or even right after removing the breathing tube, you can get a laryngeal spasm as well. Laryngeal edema, it happens when all of the swelling closes up that glottic opening, makes it either super tight or it completely just closes it off. You can see that with epiglottitis, anaphylaxis, obviously an inhalation injury. There's some other causes, but those are just really common causes. So these things can be relieved by an aggressive ventilation or even a forceful upward pull of the jaw. Muscle relaxant medications can be effective with this. However, laryngeal spasms may recur. So in the event that you've already relieved this and you're transporting your patient to the hospital, make sure that you're paying attention to them and watching for that to happen again. You're doing a good reevaluation on that patient. Laryngeal injuries. So a fractured larynx makes it hard to breathe, as you can imagine, because it's narrowing the airway. So there's a number of reasons this can happen. Weak or reduced muscle tone can cause that. Some swelling or laryngeal edema, what we talked about. With that, obviously, there's an increased effort needed to breathe. So, we'll be cognizant of that. You may have to assist ventilations or something. Then we can get onto the trauma side. So penetrating wounds, crush trauma to the larynx can cause serious airway issues due to swelling and bleeding as well. Now, in some cases, advanced airway techniques might be necessary to keep the airway open for these guys. This is kind of a page taken out of there. You notice it says 4 of 4. So this is out from the foreign body airway obstruction. I left it in because it's got the McGill forceps. In the event that you need to remove a foreign body airway obstruction, you'll insert the laryngoscope blade into the patient's mouth. And then if you see the foreign body, you'll go ahead and remove it with those McGill forceps. You don't want to go in there digging around just thinking there might be something, but if you see something, grab it. Ventilatory support. So let's get into some basics. So normal ventilation versus positive pressure ventilation. So we know with normal ventilation, the diaphragm contracts, creating a negative pressure in the chest cavity. What that does, pulls air into the chest cavity through the trachea and tries to balance the pressure inside the chest with the air pressure outside. Now, positive pressure ventilation, talking about like say a bag valve mask, that generates positive pressure, just like the name says. It pushes air into the chest from the outside. Now, there is this connection between breathing and circulation. So as the chest expands and recoils during breathing, it helps the circulatory system by acting like a pump. Now, these pressure changes in the chest assist in pulling venous blood back to the heart, improving preload and overall circulation. So some effects of positive pressure ventilation. Positive pressure ventilation requires more air to achieve the same oxygenation and ventilation as normal breathing. It raises the pressure inside those airways, which can push the chest wall out of its natural shape. Now, this leads to higher overall pressure in the chest or the interthoracic pressure. As a result, the blood flow is reduced because venous blood can't return to the heart as effectively. So less blood is pumped out of the heart. So it's important to carefully control the rate and the volume of artificial ventilation to minimize these effects. Cardiac output, effects of positive pressure ventilation. So cardiac output is determined by multiplying the amount of blood pumped with each heartbeat, so the stroke volume, by the heart rate. Heart rate times stroke volume. Under normal breathing conditions, that air flows naturally into the trachea. Now, with positive pressure ventilation, air is pushed into the trachea, but can also be forced into the esophagus. So if those ventilations are too forceful, the esophagus can open, allowing air to enter into the stomach, leading to gastric distension, or a bloated stomach basically filled with air. Remember, they're not always filled with air though. So some transport vents. They're designed to really help you kind of precisely control ventilation settings. Typically they have rate, tidal volume, or peak respiratory volume, so kind of your length of your respiration. The nice thing about that is it's consistent and reliable, and now you're hands off. So there's a couple different kinds of these ventilators that are out there. You have an AC or assist control that kind of guarantees a minimum ventilation rate while letting the patient set their own respiratory rate, meaning if they're breathing at 10 and you set it at 12, it's going to breathe for them. If they're breathing at 14 and you set it at 12, it's going to assist when needed. So if they're consistent at 14, it's not going to be needed. And then you have SIMV, synchronized intermittent mandatory ventilation. So that delivers a set rate in volume or pressure while syncing with the patient's spontaneous breaths. So that lets the patient take on more or less of the work of breathing, depending on the mandatory rate that you've set. And then pressure support. So it adds, clinician selected positive pressure to help the patient's spontaneous breaths. But they need to be able to initiate a breath for this mode to work. Now the setup's quite easy on these. Most of them are probably all the same, however they're not. So you'll need to be familiar with your own vent, but you want to connect it hopefully you're able to connect it to wall mounted oxygen. Hopefully you haven't ran it down and not swapped it out, but you connect it to your wall mounted oxygen source. However, you can put it on bottles as well. Adjust your rate, your volume, your peak inspiratory time based on your local protocols, but on the patient's age and the condition. Obviously attach it to your intubation tube into your endotracheal tube. Then you want to check breath sounds, watch for equal chest rise and fall, confirm with end tidal if you have that. Hopefully everybody has that nowadays. And the nice thing about these, it frees your hands up so you can focus on other things that you need to do, not related to managing that airway. So some additional considerations. You use about 5 liters of oxygen per minute with these. So you can see if you don't have a big bottle, you could run that thing down quite a bit. The pressure relief valve can cause some potential issues though. It can cause some hypoventilation issues with patients with poor lung compliance. It can increase airway resistance, as well as an airway obstruction. It can become an issue, leading to inadequate ventilation. So one of the big risks is that there's a risk of barotrauma if the pressure relief valve fails or if the ventilation is too forceful. CPAP. So CPAP, that's a really non-invasive way to support a patient that's struggling with breathing. So it's a great tool for managing respiratory distress caused by acute pulmonary edema. So think about your CHF patients, obstructive lung diseases. Think about like COPD, acute bronchospasm, maybe during an asthma attack. So many of these patients with these conditions might traditionally require advanced airway techniques. However, using CPAP using it especially early can prevent the need for intubation. So how it works, it increases pressure in the lungs. It helps reopen those collapsed alveoli that have collapsed due to whatever respiratory issue they have going on. It pushes more oxygen across that alveolar membrane. It moves interstitial fluid back into the pulmonary circulation. The goal of CPAP is to improve the lungs' function. So to make it easier, basically what we're saying is make it easier for the patient to breathe on their own. Typically delivered through face mask, secured with a strapping system. So it's fitted with a pressure relief valve, that face mask is, that determines the amount of pressure that's delivered to the patient. Only a preset amount of pressure is delivered to your patient, dependent on its setting. So if you set it at 5, they're going to get 5. If you set it at 10, they're going to get 10. That's in the event that you have one that you can select. So who needs CPAP? Then let's talk about indications for CPAP. CPAP's for patients in respiratory distress when their body's natural efforts can no longer meet their oxygen demands. So it addresses symptoms, not necessarily the root cause of the problem. So in the event that you have someone that's lungs are filling up with fluid secondary to CHF, it's not going to do anything for the CHF. What it's going to work on is getting that fluid pushed out of the lungs. So some general guidelines for this. They should be awake and able to follow instructions. Clear signs of moderate to severe respiratory distress due to an underlying condition. Respiratory distress is present after a submersion incident, or maybe they're breathing so fast it's reducing their overall minute volume. Patient's O2 sats below 90. But as we always say, stick to your local protocols when you're deciding who's going to get CPAP. Now, we talked about who gets it. Now, who doesn't get it? It shouldn't be used with some of these patients. So if they're unresponsive, unable to follow verbal commands, not a good patient for that. If they're experiencing respiratory arrest or agonal breathing, not a good patient. When they're unable to speak, they can't protect their own airway. Maybe they're showing signs of hypoventilation. If they're hypotensive, not going to be a good patient. Remember, that positive pressure ventilation can really start to work on that pump and drop their pressure even further. So if you suspect them having a pneumo or chest trauma, closed head injuries, some of these are not going to be good patients for CPAP. Now, who should it be avoided with? Facial trauma, cardiogenic shock, tracheostomy, GI bleeding. You see a list of things. Now, CPAP doesn't work with everybody, so if they're showing signs of respiratory failure or can't follow commands, then they're not going to, as they're progressing and you have them on CPAP, you're probably going to need to switch them over and ventilate them with a bag mask device. And of course with high flow O2. So generally, when we talking about the application of CPAP, they're generally composed of a generator, a mask, a circuit that contains the tubing, bacteria filter, one-way valve. So key concepts in CPAP functionality is what we're going to talk about. So during exhalation, because we're talking about the expiratory phase and the pressure. So during exhalation, the patient breathes out against a resistance known as the expiratory positive airway pressure, which creates PEEP. So positive end expiratory pressure. The PEEP level can be adjusted manually in the event that you have that, set to a fixed value on a PEEP valve depending on the device. So a therapeutic range is going to be somewhere between 5 to 10 centimeters of water, generally effective at that rate. But these CPAPs run on oxygen, so always make sure, as we said, that you've got a full oxygen supply. So some CPAPs use a continuous flow of oxygen, while others operate on a demand basis, only as needed. So, while you're using this, you always want to make sure that you're paying attention to how much O2 that you have left. The newer CPAP models, they'll allow you also to kind of fine-tune some things. So they'll allow you to adjust the FiO2, so kind of that amount of oxygen that they're getting. Many devices are preset to deliver around 30-35%. Some devices can go all the way up to 95% though. Now there are some complications. So patient tolerance is a big thing. So some patients can feel claustrophobic and they'll really resist using CPAP. So hopefully you have the time to kind of explain how it works and coach them through the process just to be able to make them more comfortable. Never force the mask on a patient who refuses it. Now, a risk of pneumothorax is also a challenge as well. Those high pressures generated by CPAP can lead to a pneumo if barotrauma occurs. We mentioned hypotension, so that increased chest cavity pressure from CPAP can lower blood pressure. It's rare with the lower CPAP levels, but you still want to make sure that you're monitoring their blood pressure. And then aspiration. So air can enter the stomach during CPAP use, raising the risk of aspiration if the patient vomits. So CPAP, let's just kind of talk about some key takeaways. So one thing it does, it keeps the airway open by maintaining positive pressure during both inhalation and exhalation. Prevents alveolar collapse and improves oxygen exchange across those alveolar membranes, which makes breathing easier by reducing the work of breathing. So it also helps manage some pulmonary edema by forcing that fluid back into the vasculature. So you can see there's a lot of big things, big benefits to using CPAP. Now, we mentioned some gastric distension before. So, really any form of artificial ventilation that blows air into the mouth can lead to inflating that patient's stomach with air. So some causes of complications with ventilation. Complications are more likely when excessive pressure is applied to inflate the lungs. Ventilations are delivered too quickly or too forcefully. The airway is partially blocked during ventilation attempts. These issues are commonly seen in children, but can occur frequently in adults. So improper ventilation can be harmful for several reasons. It can cause regurgitation of stomach contents, which increases the risk of aspiration. It pushes the diaphragm upward, which reduces the space available for the lungs to expand. And some of those signs that you might see is as we notice the size of their stomach is increasing, a progressively distended abdomen, and then increased resistance to bag mask ventilation efforts. So in the event that there's some complications, so if you notice signs of ventilation complications, reassess and adjust the patient's airway position as needed. Watch the chest carefully to ensure there's adequate rise and fall with each ventilation, and then keep each ventilation short. Limit to around a second or just enough time to achieve proper chest rise. Really pay attention to chest rise and fall whenever we're bagging these guys, so we do not overinflate things and as well as push too much air into the stomach. So in the event, what if we've done some of that? Well, the next thing is some invasive gastric decompression. So technique involves placing gastric tube into the stomach and using suction to remove its contents. So that helps reduce pressure on the diaphragm, which, as we mentioned, will allow the lungs to inflate properly and allow everything to work much better. So it also lowers the risk of regurgitation and aspiration too. So how's the tube inserted? The tube can be placed into the stomach through the mouth or through the nose. So using an OG tube or gastric tube, or using an NG tube, a nasogastric tube. And when might you consider using this? And that's when patients requiring positive pressure ventilation over an extended period of time. When you start to see some gastric distension, obviously it makes ventilation difficult with these patients. So that's going to be a really good reason that you would use this procedure. Precautions: anybody with known esophageal diseases, or if the esophagus is not patent, obviously. And always verify that you've placed it into the proper place, into the stomach. So an NG tube inserted through the nose to decompress the stomach. It reduces the pressure on the diaphragm, lowers the risk of regurgitation. We mentioned that already. Some considerations is most responsive patients are probably going to gag or vomit during insertion. So even if the gag reflex is diminished, they still can have that response. With patients with a decreased LOC, vomiting poses a serious airway threat. So we really want to be thoughtful about that. Now, who would not be a good candidate for that? Would be someone with severe facial trauma, especially mid-face or skull fractures. The tube could mistakenly pass through the fracture site and into the cranial vault. So in these cases, probably an OG tube would be a better route to go. And then risks: poor technique can injure the nasal passages. So if you're not using the proper technique, we can really do a lot of damage to the nasal passages, the esophagus, gastric lining. So we want to make sure that we're doing things properly with this. If they're non-intubated patients, then having that can really interfere with the seal on your bag mask, your BVM. OG inserted through the mouth instead of the nose. Its advantages and disadvantages are similar to those of the NG tube. So some of the kind of key differences: there's the no risk of nasal bleeding with an OG tube. It's safer for patients with severe facial trauma, and larger tubes can be used. So it makes it much more effective for gastric lavage, kind of just washing out the stomach whenever that needs to occur. So there are some challenges with this though. OG tubes are way less comfortable for awake patients, more likely to cause gagging. They increase the risk of vomiting during insertion. Responsive patients may attempt to bite the tube, making the procedure more difficult. So, the ideal patient would be generally preferred for an unresponsive patient who do not have a gag reflex. Now, dental appliances. There's lots of many forms of dental appliances. So you have upper and lower or both dentures, bridges, individual teeth, braces. But we want to be pretty thoughtful with this stuff when we're looking at advanced airway management and dental appliances. So if you do notice there is something, make sure it's secure or loose when evaluating the airway. This is especially critical for unresponsive patients. So leave it in place if it fits well. Remove it if it's loose to avoid complications. Now, we're clearing an obstruction from a dental appliance. If the appliance causes an airway obstruction in an unresponsive patient, then use your standard obstruction clearing techniques. So perform chest compressions if necessary, use direct laryngoscopy to visualize the obstruction, and then those McGill forceps that we just saw just a few minutes ago, that's going to help to remove the appliance in the event you have the ability to remove it. So special considerations for bridges. If the obstruction is caused by a bridge, you want to use extra caution with these because these things often have sharp metal ends that can easily injure the posterior pharynx or even the larynx. Now, don't get so caught up on dental appliances where you're not focusing on airway management. So managing the airway takes priority over dealing with these dental appliances themselves. However, it is best to usually remove these dental appliances prior to intubating to avoid interference. Now, your facial trauma patients. Lots of challenges with facial trauma patients. Cause significant swelling and bleeding, which can certainly obstruct your airway. In the event you have a lot of bleeding, just use direct pressure and then use suction to keep the airway clear. Now, complications with breathing and bleeding, obviously there's a lot of those. Patients can experience inadequate breathing and severe oropharyngeal bleeding. So use suction to clear the airway thoroughly. Provide ventilations if the patient isn't breathing adequately. If bleeding remains uncontrollable, perform some continuous suction and proceed with your intubation to secure the airway. Now, trauma, we're talking about facial trauma, so there's some additional considerations here. Cervical spine precautions. Always suspect a cervical spine injury and use your jaw thrust maneuver to open the airway. Trying to keep the head in a neutral inline position to avoid any other further spinal injuries. And then two-person intubation is going to be best here. So one maintains the neutral inline stabilization of the head, the other performs the intubation. Now, in typically intubation, if you have two people, that's going to always make it better for an intubation. However, sometimes there's only one, whether it's trauma or a full arrest or whatever. However, if you're working alone, you can stabilize a patient's head using your thighs. So kind of just right there, kind of just holding thighs like this, holding someone's head while performing the intubation. So, make sure while you're doing these, monitor for signs of complications. So looking for ventilation compliance, difficulty ventilating, and then sounds indicating some laryngeal edema. Now, in the event that this is unsuccessful, talking about a traumatic intubation, then you may have to move on to a crike to secure the airway. Advanced airway management. Now that we're getting into the meat of it, it's what everybody's waiting for, right? I guess. So, one of the most common mistakes with respiratory or cardiac arrest is to proceed with advanced airway management too early, forsaking the basic techniques of establishing and maintaining a patent airway in a hypoxic patient. So, BLS over ALS, or BLS before ALS. So we always want to make sure that we're handling good BLS before we move on to ALS. So establish and maintain that patent airway with just some basic techniques and your maneuvers that you've learned through your EMT and AHA. Now, indications. So who needs advanced airway management? Some reasons would be patients typically need advanced airway techniques for one or two main reasons. So if they have a failure to maintain a patent airway, thinking about airway obstruction or even compromise, they're a good patient. Failure to oxygenate and ventilate adequately, so thinking about respiratory failure, that's going to be one as well. Now, there's a lot of different techniques. We've got endotracheal tubes, orotracheal intubation, blind nasotracheal intubation, face-to-face intubation, King Airways, LMAs, iGels, surgical needle crikes, surgical and needle crikes, all different ways to secure those airways. Now, who doesn't? We talked about who gets it, who's it not good for. So situations where advanced airway may not be suitable include the presence of an intact GAC reflex. So inability to open the patient's mouth due to trauma or a jaw dislocation or any other pathological conditions as well. Inability to visualize the glottic opening. That makes the intubation very difficult if you're unable to see the glottic opening. So if you're unable to see those cords. Copious secretions, so thinking about vomit or blood obstructing the airway, that can definitely interfere with your device placement as well. Now, this was not in your book. It is a little bit, but I've just built a slide and we'll talk about these 7 steps. So 7 steps of 7 P's actually of RSI. I should have put that shouldn't say steps of RSI. That should say the 7 P's of RSI. So I didn't build that very well. However, the goal in preparation, we want to make sure that we got all the necessary equipment. So we're talking about medication, all of our equipment, personnel, everyone's ready. Make sure that we've got our suction, our O2, our BVM, our laryngoscope, our ET tubes, bougies, everything. Backup airway device for sure. Got to verify our meds, so sedatives and paralytics and any other adjunctive drugs you might use. Make sure that everyone knows what they're doing, who's going to intubate, who's going to ventilate, those type of things. And then you want to be prepared for complications, so a failed or a crash airway or a difficult airway. Move on to pre-oxygenation, one of the biggest steps in my opinion. Maximize oxygen reserves to prevent hypoxia and during apnea. So we want to be able to administer 100% O2 via non-rebreather mask or a BVM for preferably 3 to 5 minutes. So you might consider non-invasive positive pressure ventilation for hypoxic patients, and then use apneic oxygenation with a nasal cannula at 15 liters per minute during the procedure. If you're unsure what that is, it's okay. We're going to talk about it here in a little bit more in depth, but just be listening for those words. So, and then pre-treatment. So our goal here is to mitigate potential adverse physiological responses to intubation. What I mean by that is we're going to use some key medications for that. In the event that maybe there's some, and now this is always based on your local protocols, but there are some places that are put for patients with increased intracranial pressure or even a bronchospasm. They're using some lidocaine, atropine for bradycardia, especially in pediatric patients, fentanyl to blunt the sympathetic response in cases of head injury or cardiovascular instability. Then paralysis with induction. So we want to provide optimal conditions for intubation with sedation and muscle relaxation. So what we're thinking is, etomidate and ketamine or maybe propofol based on whatever your protocols are for your sedatives, succinylcholine or rock or whatever you're using for paralytics. Maybe you just have DAI or something that you don't have access to all of these things. However this works, you still want to have all of your meds. That's the key here. Whether you have something different or all the ones we just talked about, you want to make sure. Now remember, ensure sedation is administered before paralytics to prevent that awareness. One of the worst things I could imagine is being paralyzed yet not being sedated. Then protection and positioning. So protect against aspiration and optimize airway visualization. So we want to elevate the head to a sniffing position. Of course, that's with no spinal precautions. Positioning aids, so ramping them up, or so pillows or pads or whatever. You want to be able to try to align the ear with the sternal notch for any patients, but definitely for obese patients, because they can be some of your hardest intubations. And then placement with proof. So confirm that you have the proper ET tube placement. So direct visualization of the ET tube passing through those cords is going to be a big thing. Immediate confirmation with end-tidal CO2, kind of the gold standard there. Auscultate bilateral breath sounds. Observe for symmetrical chest rise. Secure the tube. Document the depth, meaning 22 centimeters at the teeth or 21 or whatever, wherever it is that it's at. And then post-intubation management. So make sure that your ongoing care and stability after securing the airway for post-intubation management. So confirm your ongoing end-tidal CO2, monitoring and adjusting your ventilator settings as needed, administering your analgesia, sedation for patient comfort, and then of course monitoring for complications. So hypoxia, hypotension, tube displacement, all of those kind of things. So this is kind of just a kind of a structured approach that gives you an idea about the 7 Ps. So, you know, this is just the 7 Ps. So predicting a difficult airway. There's lots of difficult airways out there, as you've probably already seen on the ambulance. It doesn't seem like there's many nice and easy, clean ones. So some physical features, conditions can give you a heads up that managing the airway might be tricky. So some of these include congenital issues, so you know, a face that looks noticeably different or asymmetrical. Recent surgeries, especially those around the head, neck, or throat, could be potential problems. Trauma, such as swelling or damage to the face or neck, infections, tumors, or cancers, those are all things to help you predict a difficult airway. So lemon. Lemon is a quick little mnemonic. It's kind of a handy little tool to help you spot potential airway challenges. So first thing is we're going to look externally. Start by checking out the patient's outward appearance. So certain features can make intubation trickier. Short, thick necks that reduces visibility, morbid obesity, which can limit your airway access, or even dental issues like an overbite. And then, hang on, sorry. Evaluate. My gosh, I just had one of those. Is that maybe a mini stroke? I don't know. So this is all about measurements to predict airway difficulty when we start looking at evaluate. So our first three, we have evaluate 3-3-2. So the first 3 in the 3-3-2 is the mouth opening. So the patient should be able to open their mouth at least 3 fingers wide. You see that in your first picture, at least 3 fingers wide. Anything less might indicate a tight airway that's harder to navigate. Doesn't mean it is, it's just telling you that it might. We're just trying to predict the difficult airways here. Second 3 is the mandible length. Ideally, the space from the tip of the chin to the hyoid bone should be 3 finger breadths. So why does it matter? Smaller mandibles don't leave much room for the tongue and epiglottis to move. This makes managing the airway much, much more challenging. And then the 2, the distance from the hyoid bone to the thyroid notch. So this should be at least 2 fingers wide. The shorter distance could mean less space for intubation or airway devices. So like I said, that's our second one in lemon. We had look, we have evaluate. Our evaluate's 3-3-2. That's going to be, we're predicting a difficult airway. So M, Mallampati. This part helps predict how challenging the intubation might be based on what you can see in the throat. So think of it kind of like, you know, a little peekaboo game here with the throat. So class 1, you see everything. Full visibility of the soft palate, uvula, tonsillar pillars. When you look at class 1 over there all the way to the left, you notice big everything, you can see everything. 2, intubation's probably going to be smooth, or not 2, I'm sorry. Talking about this intubation, it's probably going to be smooth, not a lot of issues. Now, class 2, you see most of it. The soft palate and part of the uvula are visible. So still manageable, but it may be a little more, may take a little more effort. Class 3, you see some. So only the base of the uvula and the soft palate are visible. Things might get a little bit tight in there, and intubations might be a little tricky with a class 3. However, class 4, you see nothing. So this soft palate is barely visible or not visible at all. So basically, with the class 4, buckle up. It's going to be a challenging intubation, and you're going to need solid backup plan, like a bougie or a video laryngoscope. So we move on to our, this is actually just another, I shouldn't have had this right in here because this is not necessarily part of Lemon. However, it is another grading tool. So this is just a grading tool used during laryngoscopy to assess how much of the airway anatomy is visible. It helps predict how challenging intubation might be, and it guides your next steps in airway management. So grade 1, you can see the entire glottis, including the vocal cords. I don't know if I mentioned it, it's the Cormac, I believe it's Lehane classification. So what this means when we talk about grade 1, as you can see where you see everything, this means intubation should be pretty straightforward. Grade 2, only part of the glottis is visible. So what does this mean? Intubation might be a little bit tricky, still very manageable though. Grade 3, only the epiglottis is visible, but the glottis is not. So intubation becomes a little more difficult, and you might need advanced tools or techniques like a bougie or a video laryngoscope. And then grade 4, neither the glottis nor the epiglottis is visible. This is going to be the hardest scenario. So advanced airway techniques like a supraglottic device or even a surgical airway may be something that you move on to. So it's important that you understand both of these systems. This kind of helps you gauge how difficult the intubation might be. It helps you to select the right equipment, maybe the right backup strategies, all of those things. Now, we've moved past our Mallampati, now we're into our O for obstruction. So when we're looking for that difficult airway, we want to look for anything that could block our view or interfere with placing our endotracheal tube. So several things to watch for. Foreign body obstruction obviously is one thing you can see. So anything blocking the airway, food, debris, whatever. Obesity, excess tissue can make it harder to see and manipulate the airway. Hematoma, swelling or bruising that narrows the airway or obstructs landmarks. And then hematomas, masses, any of these things that are in there can certainly obstruct your vision. And then last, N, neck mobility. That's going to play a crucial role in achieving your ideal airway positioning when we start talking about intubation. Sniffing position, typically where we want to be. Provides our best alignment for airway visualization. What we're talking about is our head slightly extended and the neck flexed. So challenges with neck mobility. The limited neck movement can make it hard to achieve the optimal position. So some common causes of this are trauma patients, primarily because they're restricted by a cervical collar or maybe a spinal injury. And then our older patients, hang on, my light went off, sorry. And then our older patients, conditions like osteoporosis or arthritis, they often reduce flexibility. So why is it important to understand these things? Because recognizing that neck mobility issues early allows you to modify your approach. This may be someone you want to go ahead and use a video or laryngoscope if that's available to you, versus just going in not really blind, but almost kind of blind where you're not sure about that yet. And here we are. We're at the end, kids, ladies and gents. So to be continued, part 3 coming.